Welcome students. Today we are going to see medical termination of pregnancy. It is a medical procedure for ending a pregnancy at any time before the period of viability. Now the period of viability by Indian law is considered as 20 weeks. So in our country we are allowed to do termination of pregnancy only till 20 weeks. This is by the Act, Medical Termination of Pregnancy Act, which was formed in 1971 and it has been enforced since 1st April of 1972. The Act was amended many a times. Before your exams, please check what are the recent amendments and then go for the exam. What are the grounds for MTP? On which reasons we can terminate any particular pregnancy? There are grounds established in this law. Medical grounds, eugenic, humanitarian, social and ethical. But in practice, the grounds which we commonly use, they are either medical, social or eugenic. Now let's see, what do we mean by medical or therapeutic grounds? It means that we want to terminate the pregnancy to save the life of that particular woman. In which cases? Suppose, for example, she has severe cardiac disease or uncontrolled diabetes, epilepsy, chronic renal diseases, malignant hypertension, intractable hyperemesis gravidarum, cervical or breast malignancy. So these are certain issues where her treatment or her life takes the priority, and on basis of that, we can terminate the pregnancy, because growing a pregnancy in such a sick woman is troublesome to her. It can endanger her own life. To save her life, we can go ahead and terminate that particular pregnancy. Social grounds, to prevent grave injury to physical and mental health of the pregnant woman. The most commonly used ground is failure of contraceptives. That means that woman didn't want this pregnancy. She was using contraceptives, but the contraceptive has failed. We all know all the contraceptives have failure rates, and thus the contraceptive has failed, and that's why this pregnancy is there. It's injurious to her mental health or physical health. She doesn't want this. So on this ground, we can terminate the pregnancy. In the form which we filled in before going for pregnancy, we have to tick or we have to mark the reason for which we are doing this. And this is the most commonly used reason, failure of contraceptives. But please remember students that this clause we can use only in married females. The law says this is useful or this ground can be there only in married females. I don't know if the law gets amended because of the changing social circumstances. There would be inclusion of unmarried women as well, because they are the ones who actually need this clause more frequently. Then the next clause is pregnancy caused by rape. If some woman is pregnant because of rape, she doesn't want to continue the pregnancy, and then our law allows us to terminate that particular pregnancy under the social grounds or under humanitarian grounds. Eugenic, where substantial risk of the child being born with serious physical and mental abnormalities, so that in his life he would be completely handicapped. In such circumstances, we are allowed to terminate that particular pregnancy. These problems can be structural, chromosomal or genetic. If there is use of teratogenic drugs in a pregnant female, if she by mistake or whether she's on some therapy and she doesn't know that she is pregnant, and she has used these drugs like thalidomide, cortisone, antimitotic drugs, antidepressants, or she gets exposed to the radiation, these drugs can cause or can lead to certain abnormalities which will create serious handicap in the next baby or in the future baby, and that's why we want to terminate that particular pregnancy. In case a pregnant woman gets viral infections like rubella, German measles, chickenpox, toxoplasma or viral hepatitis, especially in first trimester, all these viral infections can cross the placental barrier, reach the fetus and affect the fetus, and can cause many congenital anomalies in the fetus. That is why again that becomes a eugenic ground for termination of pregnancy. Insanity of the parents can also be a ground for termination, and that comes under eugenic. Now for conducting medical termination of pregnancy, we have the law mentions everything very specifically, that the person, about his training, about the center, what should be the criteria, the center has to be registered. So let's see one by one what are the criteria. The person who conducts MTP should be a registered medical practitioner. He must have assisted at least 25 MTPs or 6 months house surgeon training in OBGY, or he can be a person with diploma or degree in OBGY. The place can be government hospital, private hospital, or any center approved by government. MTP registration number that center should have. Consent. Before going ahead with the procedure, we have to take written informed consent of the woman. Please remember, MCQ can come that whose consent is necessary for MTP. Every woman has a right to abort her own pregnancy. She is the one who can decide whether the baby can be born or the baby cannot be born. She doesn't need anyone's permission on this earth to abort the pregnancy. So only woman's consent is mandatory by law to conduct MTP. But practically, we always take spouse's consent, because if something goes wrong with the patient while undergoing this procedure, we always want someone to take care of the patient or someone responsible to be around. So it's always better to involve a spouse or whosoever relative she has with her. In case of minor, if the girl is minor, that is less than 18 years of age, or if she is lunatic, mentally retarded, then we need to have consent of a parent or her guardian, whosoever comes with her. Termination of pregnancy by Indian laws can be done only till 20 weeks. Different countries have different laws. In some countries, the limit of pregnancy can be stretched, or the limit of abortion can be up to 24 weeks. Because with developing ultrasound machines, we can diagnose many anomalies, but cardiac anomalies get diagnosed only after 20 weeks, because heart is in that condition where those anomalies can be seen or can be diagnosed. After 20 weeks, if we can diagnose some very severe type of congenital cardiac anomaly, then we need to terminate the pregnancy. But right now, our law permits us only till 20 weeks. There are social activists or NGOs or medical societies asking to get the law amended and extend till 24 weeks. But till today, till we are talking, the law permits pregnancy termination only till 20 weeks of gestation. If the abortion is done after 12 weeks, we need opinion of 2 registered medical practitioners. The form has to be filled by 2 persons. It has to be signed by 2 persons if the pregnancy is more than 12 weeks. What are the prerequisites of MTP center? A registered medical practitioner, anesthetist should be there around the clock, and anesthesia facilities should be there. The center should have a well-equipped OT, and there should be facilities for blood transfusion and resuscitation if required. Facilities for proper sterilization of instruments are very important, because if proper asepsis is not followed, these terminations can lead to sepsis, septic abortion, and can be even life-threatening to the mother or to the patient. Record keeping is also very important. We have to maintain a separate register for the patient's names who are undergoing MTP, and this record we have to keep for minimum 5 years. Patient's name appear only on the register. On case paper or on the file of the patient, we always put only MTP number which is mentioned in the register. So if a patient comes, her file will never have her name. Only the name is mentioned in the register, and the register gives MTP number. That MTP number is mentioned on patient's file. This is to maintain and to respect her privacy, that we don't want everyone or anyone to come to know that she is undergoing abortion. So this is to maintain the secrecy or privacy. Consent forms, they should be in the safe custody of the hospital owner for minimum 3 years. The form which has doctor's signature, patient signature, the reason mentioned, that has to be kept in safe custody for minimum 3 years. Monthly report should be sent to the Department of Health, state government, mentioning how many MTPs were conducted. Were they of less than 12 weeks gestation or were they of more than 12 weeks gestation? So everything mentioned in the report, and this report should be sent to the Department of Health. Institution and doctor both are legally bound to observe confidentiality of the MTP procedure. We are not supposed to disclose to anyone who comes and asks details about this. We should respect her privacy and observe confidentiality about the reason, about weeks of gestation, whatever information patient has given us. Medical methods of first trimester MTP. We are going to see it in two parts. First would be first trimester methods and the second part would be second trimester method. In first trimester method, we have medical methods where we are going to use only drugs to terminate that pregnancy, and surgical methods where we are going to use surgical methods. So what are the medical methods? They are highly successful when used within 50 days, but now we can use it till 63 days. It has an advantage that it avoids hospitalization. It increases the choice. It avoids surgical and anesthetic complication. The risk is also avoided, and more patient control over the procedure. She can take the drugs as per her choice, her convenience. So patient has more control over the procedure. What are the disadvantages? The procedure is longer in duration. There is longer waiting period for completion of abortion. It requires multiple visits to the hospital. The procedure is available only till 7 weeks, or we can say 9 weeks maximum. Cannot be done after 9 weeks. And sometimes this procedure to complete needs surgical evacuation or surgical procedure. And the commonest complication of medical method of medical termination of pregnancy is incomplete abortion. This is again a commonly asked MCQ, that what is the commonest complication of medical MTP, and the answer is incomplete abortion. Suppose with the drugs patient aborts incompletely, she will have bleeding, either profuse or persistent. In that case, if she is bleeding profusely, we have to evacuate the uterus by surgical method, that is dilatation and curettage, and empty the cavity as early as possible. In case of persistent bleeding because of incomplete abortion, we have to give her antibiotic coverage and then evacuate the cavity to avoid septic abortion. Now, what are the investigations to be done once a female decides to undergo termination? The first and foremost is blood grouping and RH typing. We have to know blood group of that particular patient before she undergoes any method of termination. Because if she bleeds, then we don't have time to go and get her blood group and RH done. So we should have this investigation beforehand. Another purpose is, if she is RH negative, then we have to give anti-D to avoid RH isoimmunization. So in both the things, it helps. Then hemogram, where we want to know her hemoglobin and is there any evidence of infection at present. Blood sugar levels to know whether she is diabetic, controlled, uncontrolled. Urine routine, again to see whether there is an infection. And other serological tests, HbSAg, VDRL and HIV. Because that patient may need surgical treatment. So for our staff, for ourselves, we have to know the status of the patient, whether she is HbSAg positive, HIV positive or VDRL positive. And it's always better to get one sonography done to rule out ectopic pregnancy, first thing, to know or to confirm what is the precise gestational age. Because she has given us history of 2 months or 3 months of amenorrhea, we have clinically done the examination, but that gives us approximate period of gestation. It is always better to confirm that yes, she is pregnant, the pregnancy is intrauterine, there is no evidence of ectopic pregnancy, and the gestational age is so and so. Drugs used in medical termination is Misoprostol. RU486 is the other name. It's basically an anti-progestogen. What it does, it counteracts the action of progesterone, and thus it decreases LH secretion. We know that corpus luteum is maintained by LH and by the HCG secreted from the trophoblastic tissue, and this corpus luteum keeps secreting progesterone, which nurtures the pregnancy. But now this anti-progestogen, they go and block all the progesterone receptors. That causes decrease in LH as well as decrease HCG level. There is luteolysis, and because of luteolysis, the support of progesterone and estrogen is gone. Shedding of endometrium takes place and bleeding in the luteal phase of the cycle starts. It also causes cervical ripening and increases myometrial contraction. So it helps in kind of taking out support or stops nurturing the baby or the fetus, and then starts softening the cervix so that it gets easily dilated, and then the pregnancy or the products of conception can get expelled out. Second drug used in medical termination is Misoprostol. This is a prostaglandin, synthetic PG analog, inexpensive, stable at room temperature, and it acts by enhancing uterine contractions and causes cervical softening and dilatation. Now the fetus is not alive because of mifepristone, because of the antiprogestogen. Now we need to throw this out of the uterine cavity. So we need to give misoprostol, which will initiate uterine contraction, soften the cervix, open the cervical canal, and throw this product of conception out of the cavity. What are the contraindications for MTP with these two drugs? Ectopic pregnancy. I told you that we should rule out that there is no evidence of any ectopic. Because if we give these drugs, it may cause rupture of the ectopic pregnancy and there would be intraperitoneal hemorrhage. In chronic adrenal failure, patient on long-term corticosteroid therapy, severe anemia, coagulopathy, or anticoagulant use, active liver diseases, uncontrolled seizures, and serious diseases, these drugs are not to be used. In bronchial asthma also, prostaglandins are to be used. We are not to be used. So that these can be the MCQs, that what are the contraindication for use of medical termination of pregnancy or for use of prostaglandins. What are the regimens used for this? The first FDA approved regimen was meant for less than 7 weeks. That means less than 49 days from LMP. Last menstrual period, 49 days. RU486, 3 tablets. It comes of 200 mcg 1 tablet milligram. So 3 tablets orally to be given, followed by after 48 hours we are supposed to give 2 tablets of misoprostol, that is 400 mcg orally. This is the first regime. Now the second regime, which is given till 63 days of pregnancy, that means 9 weeks from LMP. RU486, 200 milligram orally, followed by misoprostol. Now 800 means 4 tablets to be given either vaginally after 48 hours. It can also be given orally, but vaginal route is preferred. Methotrexate can also be used, but it's not practically very much convenient to use. So the practical use of mifepristone and misoprostol is much commoner. What are the complications? There can be headache, malaise, skin rash, fever. Sometimes patient doesn't respond to these drugs and there can be failure to abort. Surgery is required in case the abortion is incomplete. Now, once we have seen the medical methods, we will go for surgical methods. Surgical methods are the ones where we need to use some surgical instrument, which first we need to dilate the cervix, then put this instrument and then suck out these products of conception from the uterine cavity. So this is a blind procedure. When we do this procedure, we use our judgment, and thus complication of surgical procedure are there which we need to understand. So let's see the methods of first trimester MTP one by one. First is menstrual regulation. Again, commonly done. In this case, patient comes to us just for delayed menses. She is not very sure whether she is pregnant or she is not pregnant. She has just missed 2 days overdue, 3 days overdue, or maybe a week or so. So in that particular case, we can just do this menstrual regulation method without even confirmation of pregnancy. So in that case, the plastic cannula, the Carmen's cannula with a plastic syringe attached to it, OPD procedure, patient in dorsal position, and we just put this plastic cannula which goes easily inside without cervical dilatation, the small size one, because this is very early pregnancy we are dealing with. We are not talking about MVP where the pregnancy is of larger duration. So we place this plastic cannula. Suction is created in the Carmen's cannula by pulling the piston behind, and then we just do this to and fro movement, and the endometrium or the residua or early products of conception are sucked into the cavity. Patient starts bleeding. So this is menstrual regulation. Now once the pregnancy is of more duration, then we should go for methods like either MVA, that is manual vacuum aspiration, or we can go for other surgical methods, that is suction evacuation and or dilatation and evacuation. In use of manual vacuum aspiration till 6 weeks, again a plastic cannula, the syringe comes which is made up of plastic. We can use it under anesthesia, and it's a very simple procedure. It avoids perforation, which is much more common with the steel instruments, that the steel cannula, suction cannula, which we are going to use in suction evacuation. Procedure is almost the same. From 6 weeks onwards till 12 weeks, the method commonly uses suction evacuation or dilatation and evacuation. Now let's see this method very in little details. Method place to be done is in the operation theatre. Investigations required. We have seen that we need blood group, RH typing, her hemoglobin. We also need to know her blood sugar, urine, HIV status, HbSAg and VDRL status. We send the patient for anesthesia fitness. Anesthetic gives her fitness. Then the procedure is to be done either under GA or under spinal anesthesia. This procedure can be combined along with operations like tubectomy, or copper T insertion can be done. Always remember that when the patient is having unwanted pregnancy, that's the best time to counsel her regarding contraception, because patient is very receptive. She has already done a mistake. By mistake she is pregnant. So now she knows that she has to go through this procedure because of not using contraceptives properly. So we should always take advantage of the situation. This is called as opportunistic counseling, that we are taking this advantage of the situation of her mental condition right now and counsel her that she should be using a contraceptive which is having less failure rate and which will reduce her troubles by having unwanted pregnancies. So once you talk to her, once you counsel her about the contraceptive use, she will accept the contraception, and then you can have MTP along with either copper T insertion, or you can go ahead with MTP with permanent method of sterilization, that is tubectomy. We will see this method in detail, that suction evacuation and dilatation and evacuation, and combined we can have sometimes the cervix to ripen, we can use some prostaglandins and then go for suction evacuation. So we were seeing the preoperative preparation, then we have taken written consent, counseling we have done. In counseling we should tell her what is the procedure we are going to do. We have to tell her that it's a blind procedure, so it has complications like perforation. If there is perforation, there can be injury to the intestines, to the neighboring structures, there would be bleeding. In case if the perforation is larger, we may have to open her abdomen and correct the rent on the uterus. So all these things should be discussed with the parent, with the patient and her guardian or spouse, whosoever has come. Proper examination to be done, gestational age to be confirmed, ultrasound to confirm our clinical findings, and once everything is done, then we should take the patient for the procedure. Done in OT, anesthesia I have already told you, patient is given lithotomy position, cleaning, painting, draping is done, cervix is held with valsalum, and then cervix is dilated with Hagar's dilator gradually. Now the rule is we want to insert the cannula which equals to weeks of gestation. Now suppose patient is 9 weeks pregnant, we want to use the suction cannula which is of 9 number. So we need to dilate the cervix at least till 9 number or 1 number extra so that the cannula can go in and come out easily. So we dilate the cervix till 9 or 10 number. Once the cervix is sufficiently dilated, then we insert the suction cannula. Suction cannula is attached to the suction machine. Machine is switched on. Suction is created. We keep the thumb and on the thumb rest and cover the opening there. So the vacuum gets transferred to the tip of the suction cannula. We have rotatory movements through 360 degrees and at the same time movements to separate the products of conception. And by doing these kind of movements, we rotate the cannula all over and the products of conception are getting sucked out, which we can see through the semi-transparent tube, plastic tube. Once the products stop coming, bleeding is less and there is gripping sensation. That means the uterine cavity is empty now. It starts gripping on the suction cannula. Once it happens, we know that almost all the products of conception are taken out. At that particular time, we switch off the machine, remove the thumb from the thumb rest and then remove the suction cannula. Once we remove that, then just to confirm whether the procedure is complete, we use check curettage with the curette. We curette all the walls till the gritty fillings come. Once the gritting sensation comes, bleeding is less, we are sure that the whole of the cavity is empty and then we say that this procedure is empty. Then we can insert copper T if required or go ahead for tubectomy. Post-abortal phase, observation is must. Contraception advice we have already done. Prophylactic antibiotics should be given. If she is Rh negative, then anti-D and follow up the patient after next menstruation. So this completes suction evacuation. We'll stop here and then we'll see dilatation and evacuation and the difference in these two procedures.